Welcome, everybody. We're going to let you all virtually get settled in the room, but I'm really thrilled to be bringing you another webinar. And here we are in 2021. You know, we've seen all the memes going back and forth. Do we know the difference between this March and last March? I think what we can safely say is collectively from MPTF and our partners, who you'll hear from today on behalf of UCLA Health, Dan Karlin, who's absolutely phenomenal. We're so grateful for you to be here. We're grateful to exist. And we're grateful to be celebrating our 100-year anniversary in such a strange time. But as our founder said, you know, we have words that stick with us so much. By the way, let me introduce myself. Many of you maybe don't know who I am. My name is Courteney Bailey. I have the honor of being a part of MPTF as our Chief Development Officer, working under our President and CEO, Bob Beecher. And I just, again, want to thank you all for being here. These webinars are based in what really secures and grounds our mission, which is we see a need and we fill it. This is the need, navigating COVID and serious illness. This is something, COVID has not been something we've navigated on a daily because this is new, but we navigate serious illness. We navigate life's curveballs. This is what we do. I think all nonprofits probably wish we didn't exist, but we're grateful to be able to serve a population because unless anyone can tell me differently, people will always need help. And we are here to help each other. And to be this safety net is pretty fantastic. We have, again, today, our Chief Innovation Officer and practicing geriatrician, among many other hyphenates, Dr. Scott Kaiser, who will be moderating our discussion. I see he's spotlighted now with Dan Karlin, Dr. Dan Karlin, and Linda Healy, who is such a blessing to us. So I just wanted to point out a couple of things. This is our 100th year, and none of this is about fundraising. Look, yes, am I here to build relationships to fundraise? Not today. Absolutely not today. Part of us turning 100 is bringing awareness to our mission, to our population, that we are a resource. And it's not only us, we direct people to resources above and beyond what we do. We are a community, so thanks for showing up. We have an incredible amount of RSVPs today. Be active in the chat, send us some questions. We're recording this. We can offer it to your locals, your guilds as a resource. So thank you again. And we want to thank, we have an ad campaign that's really based around that mission that Mary Pickford set forth, which is, I didn't think about it. These are these, without being redundant, I didn't think about it moments, right? COVID, who thought about it? Maybe people like Scott and Dr. Karlin thought about these are possibilities, and Linda, but you don't think about it. You don't think about necessarily, or maybe you don't want to think about your parents aging or you dealing with something traumatic or your children. But here we are, and this is why we exist. So deadline.com, their homepage has been so lovely to offer part of our ad campaign, which features Alex Aguilar, one of the members of our IATSE, you know, of our locals, who's incredible, who has a beautiful story, someone we featured before. And also, please check out our website, mptf.com, for any resources you may need. Again, thank you so much for joining us. I'm going to throw it to Scott Kaiser. I'll join you at the end. If you have any questions, Courteney.bailey@mptf.com. We'll put these things in the chat. So grateful for you to be here today. Happy Wednesday. Happy International, I think it's Nutrition Month, Women's Month, you know, all the months, but those should be every month. Black History Month, all these things. These are what we think about every day. So without further ado, Scott, please take it away.
Thanks, Courteney. Thanks, Courteney. And the rain's really coming down here where I am, so I'm glad to be here with you guys, not driving around in the rain there. And it's a beautiful day. Very, very much looking forward to our conversation today, which I think could not be more timely. Really thinking about, we're going to break this into two parts, really. One is, you know, it's time for another COVID update. We just want to take a look at kind of where we are. I mean, is it over yet? What's going on with vaccines? What's the latest, talking variants, all of that. So Dr. Karlin's been pulling all-nighters to make sure that he's got the latest news to keep us up to date on COVID. And then we'll transition into, COVID has really upended lives for so many people, transition into what happens when your life is upended by the unexpected, and particularly navigating serious illness, and how palliative care can be a resource, which is why I'm so pleased to have two palliative care dynamos here today. Dr. Daniel Karlin, who is an assistant clinical professor in palliative care. And Dr. Karlin, Dr. Dan, is it true you grew up in Woodland Hills, driving by the campus, wondering kind of what was on the other side?
Yeah, I kept on coming by and thinking, man, this must be an awesome place to work. I hope I end up there someday. And then it all comes true.
We've made his dreams come true. And then I'll go through his credentials here. It's a long list. You'll see a theme in the introductions here of a lot of rivalries. Undergrad at Cal Berkeley, med school, and then an internal medicine and a pediatrics combined residency, a real underachiever at UCLA, then followed by a hospice and palliative medicine at UCSD, which, not to be a narcissist, but actually my first introduction to palliative care was because one of my faculty had trained in this amazing, groundbreaking UCSD Scripps program. Really, so, must be good. And he focuses on palliative care throughout life transition and education and communication skills. So very excited that we now have Dan Karlin as part of our MPTF UCLA palliative care team. Has been an awesome addition. And I'm sure he's going to be inundated after this webinar. And then Linda Healy, who's been a nurse practitioner for over 20 years and holds all sorts of certifications. She received her master's as a family nurse practitioner at USC. The rivalries continue here. And she did a postmaster certification as a gerontologic nurse practitioner at UCLA, and has a hospice and palliative care certification. But, most importantly, I think Linda has been with Motion Picture Television Fund, MPTF, for over 20 years, and is our director of palliative care and geriatric services, which includes our incredible second to none award-winning MPTF palliative care team. So with that, I think we should just hop right into it with the COVID update. I guess the last piece of housekeeping is we got some great questions ahead of time, and I'm already seeing people active in the chat. Looking at the attendees, great to see all sorts of familiar faces, some new folks. So really glad to have everybody here. Please chime in, use the chat, don't be shy, and let's get started. So Dan, Linda, both of you, when's COVID going to be in the past tense? Is COVID over?
Not yet.
Yeah, I think we're still a ways away. I was just checking the data for the most recent infection case rates, and we are about 4,000 a day in California as a whole, and we're kind of hitting that mark of 16 cases in LA County for every 100,000 people. And what that means is, to put it on a scale, that's sort of where we were in that what felt like a great period, October, November, before the holiday surges. And so kind of back to that point as before, but that's still quite up there. And we're still not out of the woods yet.
Yeah, so I know, Linda, we've sort of experienced it firsthand, where we had this surge and then a lull and then a surge. But thankfully, I mean, even though overall case rates are still high compared to where we were before, things have calmed down a little bit.
They have. We, I think part of the issue, obviously the holiday surges, we had Thanksgiving that then went into the winter holidays, Hanukkah and Christmas, and then that went into New Year's, and it just, everything kept building. part of it, I think though, was people let their guard down.
Mhm.
And that's the big thing. Right now, we're in a better place. Our LA County's positivity rate, which is, the number of cases that are coming up positive in the number of cases that are being tested, we're down to 2.3%. In January, we were almost at 22% at the beginning of January. We just had this tremendous surge in LA County, where 100% of all ICU beds were spoken for and everything else was going on. And so now that we're seeing things somewhat coming down and something somewhat staying under control, the big thing is not to let our guard down and say, okay, it's gone. I can just go back to life as usual as it was in 2018.
Yeah, right. Not let our guard down is kind of the take home message there, because as Dan, you were pointing out, you look at those numbers. I mean, those numbers would have been shocking to us before. We've kind of become a little bit sort of numb to it all, I guess.
Mm-hmm. And I think right now we're in this race in that, can we get enough people vaccinated in time before we have another surge, before there's another major holiday that folks might get together and pass it along again? Because even think about it, in November, this was how many new infections we were having per day. And from there, we spiked all the way up when people started getting together. So again, I'm hopeful that with the vaccines coming in, we'll start to block any big expansion of infections, though. But
yeah,
a bit of a race against time.
So that really is the difference now. The race is that the vaccines really are this critical driver. So without getting political, not a very intelligent, at least from the data, time to stop wearing masks and open everything up like without any restraint. We need to kind of keep our guard up and then not let our guard down. And then the vaccines really are remarkable in terms of the potential protection. So let's talk about the vaccines. Yeah. And finally, it seems like more's coming because we need, as you said, it's a race. So right now we have 3 vaccines out.
Yeah. So we have the Pfizer and Moderna vaccines, which are the mRNA-based vaccines. And then we have the Johnson & Johnson, which is your more classical one. A lot of folks have been hearing different things about each one. There's the Pfizer and Moderna ones are at that 95% or thereabouts the efficacy level, meaning that it's preventing about 95% of infections. On top of that, it's even actually curtailing all those asymptomatic cases where folks were getting sick and then not having a ton of symptoms, but still transmitting the virus. It's become incredibly effective. The data out of Israel, where they've been really, really doing widespread vaccines, is actually pretty amazing that it can stop the virus in its tracks. The Johnson & Johnson vaccine is also extremely effective, and it works in different ways, meaning that it does not work in the same mRNA way. But what they also tested too was, of those who did get sick, what were their outcomes? And it stopped all hospitalizations related to COVID and all deaths related to COVID. And it's sort of like taking vaccines for different reasons. It can be that you're wanting to prevent all the infectious cases, but you might have some slip through and a person's still infectious, or you could protect a ton of people and have no hospitalizations related to COVID. That's still amazingly effective. One thing that people tend to focus on is that number 72% for the Johnson & Johnson vaccine. Again, I wouldn't get too tripped up by that, because what we're talking about is that if you get this vaccine, it's showing us we're having like almost no bad outcomes to COVID. If you're worried about you might potentially pass it on, yeah, you're still at risk of getting it and passing it on to others, but they're also thinking that vaccine too reduces how infectious you are. So honestly, I cannot recommend all of them enough. It's okay to get all of them. Everything you're hearing about the differences, just whatever is available, take the very first one you can get.
Yeah.
Absolutely. Yeah. And I think that going back to what Dan said about 72% and people worry, well, that, that's leaving me at, 28% chance of getting COVID. The flu shot, which is, pushed every year and supported by healthcare work, healthcare industry, professionals, is 20 to 40% effective, usually. So it's like, and that's good. That's a good number. We don't like that one. So you're talking 72%. These vaccines for COVID far outperform what we're all lining up to get every winter or not thinking anything of.
Yeah, I mean, and as Dr. Karlin said, 72% protection, but nearly like near 100% chance that you won't get hospitalized and would not have a terrible life-ending outcome. I mean, that's saving lives, and we just, the fact that we can maybe get it out to more people more quickly, one and done, easier distribution. I mean, this is just amazing, and that we have all three. So you guys definitely sound like you're of the school of, without question, don't jockey for position for one or the other. Which one would you take would be the first one you could get?
Yeah, just
Absolutely.
go for it.
Yeah, just get whichever one you can get first, and then no safety concerns about either any of the available three that you would have about getting it.
None. And in fact, actually, we're looking through this. There's the only allergies that folks have had to be concerned about are if you're allergic to a polyethylene glycol kind of thing. There's nothing that would really prevent you from being able to get this. So what I've been telling folks is just roll up your sleeve and just run shoulder first into any available clinic, into wherever you see a needle. If it's that simple.
Yeah, yeah. And so one of the questions that we did get ahead of the meeting today was, you know, people are still a little kind of suspicious of these vaccines that work in this new way. So one question was, will the mRNA change my DNA? You know, is there some kind of genetic engineering at play here? And just at least to address this attendee's concern and to speak it to more generally, any comments on that?
I would say, the short answer is no, it won't. It can't. And when I know people get hung up on saying it was all pushed so quickly. It all came through, the vaccines came through so quickly. This is all brand new technology, but the mRNA vaccine research has been going on for nearly 30 years, getting ready and preparing and investigating. And what's this? So there was a whole platform of research and data that these vaccines were built upon, and that we were able to pass very quickly. And a lot of that was just because there was finally a collaboration and between government regulation and the manufacturers, which doesn't usually exist. It's a very, you go through this step, then you go through this step, then you know, so it's a very methodical, dragged out process, and they were able to do things much more quickly and streamlined. So I don't think there needs to be any worry about that. There's not research behind it. It's not going to change your DNA. And that there's not that this was just, you know, somebody had a whim and now they're putting it in people's arms. It's a proven, you know, it's proven science with this.
Yeah, and in fact, so to your point, Linda, remember SARS? Remember when we all heard about SARS and it was going to be the next big thing that spread? That was actually when the research for this started. That's when we started looking at how can you develop a vaccine for coronaviruses. But as that passed, there wasn't as much push to get that out there, and now we had it. So it's kind of amazing what science can do when you just put your foot on the gas pedal all around the world.
Yeah, really remarkable achievement. And then in terms of this whole mRNA thing, the way a vaccine researcher explained it to me was that the mRNA message goes into the cell, gives instructions, and then it just dissolves. It disappears, and it's not going to be able to influence anything given. So they explained it as a Snapchat message. So I had to understand what Snapchat is, but basically, yeah, it's like messages that disappear. So I thought that was reassuring, and I think it's amazing. And I think the ability for them to leverage this technology to make adjustments, like should there be significant variation in the genetic code of the virus, and the amount of collaboration and all that went into it's really remarkable. In terms of there are plenty of people who are eager to get vaccinated, and the problem has been finding how they can get it fast enough and navigating all the online stuff. So we could talk about that. And then there are people who still have concerns, right? Are hesitant to get the vaccine. So there's a lot of ways we could go with that. And I'd like to hit on that. But then I'd like to go to one other thing, is that for a while it was like, great, you get the vaccine, and then what? You still have to wear your mask, wash your hands, can't touch anybody, stay in your cell, what's the why? Why bother besides the public good? Why would I what's in it for me? And lately the CDC has come out with some new guidelines that are kind of really good, consistent with the data. But where do you want to go? You could go wherever you guys want with all of those. I threw out a lot of stuff there that I know you're passionate about. Let's start with you, Dr. Karlin.
Can I talk about what you can do now? Because that has been the biggest change in all of our lives. And
Yeah.
you know, that actually just came as a result. So just in the planning of this, from 1 week to the next, as we were talking about this, the CDC came out with their recommendations about what can you do now once you're vaccinated. And it's so great to hear that they're actually saying, yes, if you are with other vaccinated adults, you can get together in a small group. They don't really tell you what like small, medium, and large are, but you can get together in a small group indoors and share a meal. You can see other folks that are vaccinated. You can spend that time. I'm looking even at the exact guidelines right now, but it is so wonderful to be able to do that. And then, you know, you can do it potentially with that. Sometimes they're even saying it's okay to go with other folks in an unvaccinated household without a mask if you yourself are protected, just because one person protected isn't going to be able to spread it to the other. So they're also saying that now they're feeling a bit more comfortable that if older adults are vaccinated, they can go see their grandkids as well. So I know my parents are extremely excited to do that. So they're really looking forward to it. There's still things that they're saying that it's not a great idea just because these aren't perfect vaccines at spreading transmission, that if you're doing a large event where we're getting into the 10s and 20s of people, that is still a way to spread this. And I would say that that's still kind of off the table. But I mean, we're now back in Costco. So I have definitely felt that we're able to do that once again and feel safe about it. They're still saying hold off on travel as much as you can if it's not absolutely essential. And yeah, but I think we're starting to see a little bit more normalcy, at least in the day-to-day life. I will say too, now that we're, you know, in the hospital, we're working with a lot of colleagues, and it's just nice to hug people again. It's just nice to be able to like physically embrace someone. So those are the changes. So if that's like not enough to spur you to get a vaccine, I don't know what else is.
Right. If you won't die and you won't end up in a hospital, and you get to hug people. I mean, come on. Even if it did modify your DNA, that would be worth it. No, in all seriousness, kidding aside, I mean, this is a big deal. I mean, this has been so meaningful. I know people who've been wanting just disconnected from loved ones and are now able to give each other a hug and sit down and have a meal. All these things that we could so easily take for granted. To be able to have those back, I mean, I know it's a major benefit. And Linda, are you starting to see that within our patients and on our campus with our residents?
We're starting to. We're not at the hugging stage yet, but then again, it's the CDC recommendation. The new recommendations just came out the beginning of this week, but we are seeing where we're finally starting to get family visits again. We were shut down from just before Thanksgiving until a week ago, 2 weeks ago max, that not having, visitation on campus, not even outdoors 6 feet apart with PPE on. And we're at least back at that. We are though starting to have some small group dining. We are trying to keep people not at the same table on top of each other, but the table spaced apart a little bit, but they can sit out and actually have a meal and see their friends and that such. And the thirst we all have for that kind of contact. I can't tell you the joy the atmosphere was in the open air plaza here on campus when we were doing the vaccines for the residents, and that they were seeing each other in real life. There they were. There was their friend, 6 feet away at another chair, and it was just this celebratory atmosphere because everybody's just really thirsting for contact. Zoom's been we've all gotten used to Zoom, but it's not the same thing as actually just seeing somebody and being able to sit with them. And so that's really huge. And I do think though, again, let's go slow, enjoy Costco and enjoy seeing the grandparents and things. I mean, I talk about hugs, but I mean, it's going back to Costco. But anyway, it's, enjoy those things, but they are cautioning, do it with members of one other household. Don't do the family gathering yet where people where 3 households have come together, and just because you all love each other and are related to each other, that still doesn't mean that that's necessarily the safest practice yet. You know,
Yeah.
getting there. We just need more people to get vaccinated.
Yeah, and I'll tell you right now, wherever I go in public, I'm still wearing a mask because it's so important for me to signify not just that I'm protecting myself or protecting others, but to show in public that there needs to still be this diligence, there still needs to be this caution so that folks don't feel like, oh, it's coming and therefore like it's okay to start taking off our masks entirely. So it's still something that I would just recommend, just that we're all on top of it so that those who have not yet gotten the vaccine can still feel like they're being protected in public.
Yeah.
Because prevention truly is our best protection. I mean, we've made advances in treatment. From where we were back last March and April, there have been advances and some things discovered, but this is still, it can be a devastating infection and a deadly infection. And so really preventing from getting it in the first place, or preventing it from getting, from having one of those really serious cases, that's our best defense. We can't just count on, oh, well, they'll just give me some medicine, I'll be fine.
Yeah, and with the vaccine rollout challenges and production challenge, I mean, there's so many people wanting the vaccine. And needing the vaccine. We just need to hang on a little bit more and remain diligent. No,
I was just going to say, in terms of the frustration people are having with getting vaccine, is just don't give up. I mean, the website, I know that the vaccine sign up site keeps crashing and sites keep changing. Just don't give up. Just keep trying. You know, it's kind of like, you know, play the lottery every day. Just try to get on and get an appointment for yourself.
Yeah. I heard about this thing in New York. My sister-in-law just got the vaccine yesterday. There's a program in New York City called Vaccine Vultures, where they let you, there's that one extra dose. They'll let folks know about it. And then whoever gets there first, they can rush in to get that extra dose. So I do know of folks who have been hanging around clinics, just checking in, is there that extra dose? It shouldn't have to come to that. I think the rollout's about to pick up steam just so soon.
Yeah.
It's gonna come really quickly. So.
Yeah, we better hope so, because unfortunately all of this is just added to some of the inequity in the vaccine distribution. And so I think there's also a component of help somebody else get vaccinated. Talk to somebody if you have knowledge and information about hesitancy, or if somebody's having an issue just navigating the online system. And, hats off to our social workers who've been, helping people navigate this impenetrable system. Somebody's expected to log on to something and, they just are used to a flip phone or a landline phone, and volunteers. I was very heartened to see that there is a program in California now that if you volunteer, you can move up in terms of your vaccine eligibility. Now, the people who are really eager to vaccine told me they went on and there's no volunteer opportunities available currently if you log on to that. But little by little, I mean, I hope that's the direction that we keep going in. We did have a question that came in here that new people are saying the vaccines are helping the COVID long haulers with symptoms, with their lingering symptoms. I mean, before you guys answer, I don't know if you've seen any of that data. I would say, there's a lot of things that come out anecdotally, and there's a lot of stuff that could very much be true. But a lot of times, if you really, it's wise to wait till something's been sufficiently studied. And I just don't know if that's been sufficiently studied yet. I know long haulers have been studied a lot, and it's unbelievable. I have patients who are just really continuing to struggle. Another reason you don't want to get COVID if you haven't had it yet. But have you guys seen any data on that, just for our attendee here at this question? Yeah. So we'll thank you for we'll keep our eye out for that data. I wouldn't be surprised if it makes sense theoretically. And if there are anecdotal reports, but I just don't know if that's been studied yet.
I will say one point to that is, even if you had COVID, please get the vaccine. Please.
Right.
They're usually recommending about 3 months since your infection, but we don't anticipate that having COVID itself will give you long-lasting protection with those antibodies. So please still get the vaccine. Excellent.
Yeah, crystal clear on that. Don't think, I've already had COVID, don't worry about it. No, get the vaccine, get the vaccine. Linda, when you were talking about kind of vaccination on campus and family visits and just sort of the experience on campus. I'm curious, I'd love to get your perspective as a clinician who's been frontline, treating COVID, and your experience through MPTF. Any reflections? I know even though we've had a little bit of lull, I know you're still in it. But
wow. I have to say, I mean, I've been with MPTF for a number of years before COVID hit. And we had our first case diagnosed the last day of March. We opened up our COVID unit on April 1st. And it's been, this past year or the last 11 months, I have never been more proud to be a part of an organization as this one. The response was absolutely amazing of people just stepping up and coming in. And back then in April, nobody knew really how it was transmitted and were they putting their lives at risk by coming to work. And yet people showed up and did what needed to be done. And, we lost some. We had 17 residents that tested positive last April, and we lost 6 of them. But 11 of them returned home. Returned back to their rooms, and that was the care that they got here, and they stayed here on campus in our care. We don't have an acute hospital that's doing medical things. We have an acute psychiatric hospital, but so they were just being diligently cared for by the UCLA physicians who were staffing the COVID unit, the nursing staff, all of us that were supporting, and that was our outcome. We went through the summer, we did fine-ish, a lot of testing. We learned a lot about testing. I think the country's learned a lot about testing over the last year. Somehow I ended up as the director of the testing lab, but again, it was kind of like being here on campus. If you had a head and there was a hat that needed to be stuck on it, then you took it. But we now have a high complexity lab on campus, and we're able to do, PCR testing, and we're diligent about that in screening. And that's how we ended up uncovering our second outbreak, which happened in December. And so we've gone through two episodes of actually having COVID spreading on campus, but we were able to shut it down both times very quickly by identifying who needed to be isolated, by caring for them. And it's just, it's a year that no one's going to forget. 2020 is burned into all of us, but I have to say, if I had to go through 2020, I'm glad I did it here.
Yeah. Dr. Karlin, you're dispatched from the front line. I know you work in hospitals as well as the palliative care service. Tell us.
Yeah, so the hospital, honestly, for the most part, I think it almost seems quite silly to think of the months of March and April last year for our level of concern compared to how many of the cases we're seeing as the year went on. And I think perhaps the absolute worst was just in December and January of this year, where we were absolutely overwhelmed in the hospital. And even more so, the county hospital system was really hit so hard. And the stories that are coming out of there from my physician colleagues are just absolutely dreadful. It's horrible to hear that so many families were forced to make really difficult choices about what to do for their loved one in the heat of the moment with limited resources available, and trying to decide what would their loved one want. Would they want to be kept alive on a ventilator? Would they want to get a tracheostomy to keep pushing for this? And it was a really horrible situation. And then it's really started to die down. So it's come back, but I think what still lingers with me is that we saw so many situations where it was folks in the most extreme emotional situation that they've ever been in their lives, but without the support of their family. And I will never forget that one of the nurses told me that the worst day of her entire career, her entire life, is the day that we stopped allowing visitors in the hospital. She had to go to the bone marrow transplant unit. These patients who are here for upwards of 100 days, relying on their family, and she had to go by room and say, I have to ask you to leave the hospital. And that's what I think has been some of the most challenging pieces for me, is it isn't just the fact that we have lost so many. It's the fact that so many have been lost alone, separated from their families, struggling to find some meaning or some connection. And really part of the battle has been, how do we give them that hope and that sense that they're not alone in all of this? That's been one of the most difficult parts for me. But I definitely see this getting better. And what I've seen on the outpatient side is that it's those same things just magnified in the day-to-day life. It's that sense of isolation that folks are feeling, the sense of, what is my purpose in life these days when I feel cut off from the rest of my community? And that's what's actually been really meaningful, is to work with folks on that, whether it's in the hospital setting or in our palliative clinic, and to help them feel more grounded as they're navigating through this.
Yeah, you talk about that terrible experience of people being seriously ill and cut off from their families, and that's so anachronistic to everything that palliative care is about. You're both palliative care providers, and palliative care is really kind of special within medicine, and to the degree to which family, caregivers, a whole team is so central, that people hopefully don't navigate serious illness in isolation. I want us to talk a little bit about palliative care, because it's a great specialty, great set of services that's very misunderstood. And I also see that, COVID is a time where we've had to deal with serious illness on an unprecedented scale, as you both just so eloquently described. What has it taught us about, palliative care? But let's just start with, what is palliative care? Because, there's a lot of misunderstanding. Linda, do you want to go for that?
Sure. So the palliative care is a recognized medical specialty, and it's focused on treating people with serious illness, not necessarily to treat their illness itself, but to treat the symptom burden around that. It's done in conjunction with whatever other treatment's going on, if there's other treatment going on, and it's really a team sport, because no person is only their physical being. No person is only their diagnosis. And so the things that keep somebody awake at night may be their pain or shortness of breath or something from their cancer or heart disease or whatever their illness is. But it may just as easily be, I can't work right now. How am I going to pay my bill? Who's going to take care of my family? Why is this happening to me? Why is it happening now? And, those are things that it doesn't, one person can't possibly be the resource to answer and address all those things. So palliative care involves physicians, nurses, social workers, chaplains, as really just taking care of the whole person. And the whole person includes not only the identified patient, but their family, because no person is sometimes dealing with an illness is almost easier than watching somebody you love dealing with an illness. So it doesn't require a terminal prognosis. It's really based on need, not prognosis. It's based on what does this person need, and can their needs be met through standard care, or do they need that extra layer of support?
Dr. Karlin, anything else to add about what is palliative care?
Yeah, I'd love to give an example. I actually have a patient that I've been working with recently. He's a young man with young kids who was diagnosed with a rectal cancer that he is going to be cured from. Thank God this kid is going to be cured from it. But he got sent to us right as soon as the diagnosis was made. And it's amazing what we can do when we start early on with someone. So he said, my biggest goal is to not lose the function of my hands. He's an animator. He wants to keep that. It is how he is going to stay in the industry. So we said, all right, great. We are going to make sure that anything you're getting chemotherapy wise, we will work around it to prevent any nerve damage that is caused by that chemotherapy regimen that you're on. He was worried about nausea. We're like, great, let's make sure you have all the anti-nausea medications you need in advance, not once it's already a problem. It's being on top of these things. And then, one of the things that came out, it wasn't about his pain. It wasn't about his nausea. It was the fact that he had been beating himself thinking, what did I do to bring on the cancer? And so we tackled that and we talked through it. And it's that sense of being able to work through not just the physical complaints, not just the strict biological science-based things, but also speak to the soul and help the actual person that's in there get through what they're going through, that's what makes it so rewarding. So I honestly couldn't pick a better field, and I honestly couldn't pick a better team to be doing this with.
So I heard, just want to unpack some of what I heard from both of you in terms of a bunch of myths and misconceptions about palliative care. So one is that it's not just for terminal, if you have some terminal illness, right? So serious illness. The other thing is, it's not like, okay, everything else has failed, now let's call in palliative care. Dr. Karlin, you just said the earlier we can be involved in serious illness care, the better. And the science, if you're a skeptic, the science supports that, right? That if you bring palliative care in early, people have less symptoms, people have better experience, and people even do better, including living longer.
Exactly. Yeah, they looked at lung cancer and they said, let's start folks off with palliative care right from the very start. Those folks lived longer and lived better than those who did not have palliative care. So whenever somebody's calling in palliative care, it's not because they're worried about it shouldn't be because they're worried about what's going to happen. It's just going to be, we are an integral part of making the experience more tolerable.
So when somebody says, well, we're just not ready for that yet, maybe they aren't for some reason, but it's not because calling in palliative care is waving the white flag or giving up. In fact, it's adding more, it's layering on care and support.
Right.
And Linda, you often talk about there's palliative medicine, right? Like, you know, a clinician can come in and look at symptoms and even discuss goals of care and stuff. But then there's also, as we move into talking about palliative care at MPTF, but talk about palliative care beyond palliative medicine.
Well, I think that was when I go back to the questions that keep people awake at night. It's not just the physical, it's not just the medicine part of it. And yes, there's very transdisciplinary in that the physician does know a bit about the existential care and does know a bit about the psychosocial, and the chaplain knows a little bit about the clinical stuff, and the social worker knows a bit about both. But each one has their area of expertise, and so it's bringing in 4 experts when we add in the RN layer too, that actually bring, each one creates a fuller experience for the patient, a fuller care. One person by themselves can't know everything.
Mm-hmm.
4 disciplines together, you've got bases pretty well covered,
Right.
For the start.
So lots of disciplines. I mean, you could go see lots of different specialists, right? So one is just seeing getting lots of different perspectives: chaplaincy, social work, nutrition, nursing, pharmacy, right? And then actually getting them to work together as a cohesive team. And what's the guiding principle of this team, right? I mean, it sounds like it's what the patient and family most want. How do you do that? Dr. Karlin and Linda, you both, I'm thinking Dr. Karlin, I know you focus on communications. How do you, I don't know what I want. I mean, and you're the expert. How do you help people figure out? I mean, they've got, all of a sudden life's upended. You're seriously ill. You didn't plan for this. How do you help people figure out what matters most to them?
Yeah, that's such a good question. And I will say, it's being in palliative care is the best ego check for doctors, because it makes us recognize that we are not the center of the world. It's a wonderful thing, because I love not having all the answers. I love relying on my chaplain to get to the deep existential questions. I love that my social worker knows how to talk about life struggles, but I love that we can all do it together. And what comes out of that is way more than each of our individual parts. So when we're talking about getting to someone to plan ahead and talk about what matters, what I love is that we actually take it away from all of the medical conversations that a person may have had with their doctors about this chemotherapy or that treatment or this surgery. And we say, what actually matters to you as a person? Who are you defined by? What are you defined by as a person in terms of your values? What have you held on to that actually makes you feel like connected to yourself? And then what we all try to do as a team is say, okay, this is the picture of a person. This is their core values. How do we shape the medical treatments the life situations, the planning for the future around those core values. So very often when I'm talking to folks, I actually just say that as a physician, I am in this palliative role, I am more like an interpreter. I am more someone who's trying to understand the human aspect and put it into terms that a lot of doctors and clinical staff can better understand about what are someone's preferences. I'm seeing one of the question and answers about advanced directives and things like that. That's absolutely what we do. That is absolutely the thing. And a lot of what we do is just normalizing this process, in that it's not necessarily about death and dying. It's about, how do you want to keep living? What is life? What brings you meaning? And how do we reflect that in a document that protects your wishes? So I'm so glad that folks take that on themselves to fill that out, but we're always here as a resource to help folks do that.
Absolutely. Linda?
I only just comment and just add on to what Dan said, and that's, again, palliative care is about living with a serious illness. It's about, you're dying now.
Yeah.
It is all about that helping somebody define for themselves what's the right path for them, and then supporting them in that. It's not for us to come in and say, this is where you need to go.
And just some of the examples that we've covered happen to be cancer diagnoses, but can you share some other types of situations where palliative care has been helpful, some common medical conditions, diagnoses that our teams are well equipped to care for?
Dementia, any of the progressive neurological disorders like multiple sclerosis, ALS, frailty. Sometimes we just have people that just have a lot of things wrong with them because their body's just giving out and they've become frail. And so they have diabetes and heart problems and maybe, COPD, a lung problem, and some other things. And any one by itself may be manageable, but the burden of everything just takes that extra attention. Any of the organ failures, if you have heart failure, kidney failure, or liver failure, any of those things also warrant a palliative care referral. Basically, if you're just feeling overwhelmed, if you're struggling with a serious condition and you're feeling overwhelmed and feeling like, I just can't cope with this, then asking for a palliative care referral is really, you deserve that. Nobody should have to go through something like this, go through a serious illness alone.
Yeah. Yeah. And just to highlight, in the beginning, you talked about progressive neurodegenerative, like, so Parkinson's, ALS, but then you mentioned dementia, and people get confused. So Alzheimer's, dementia, the terms are kind of used interchangeably, right? There's a whole bunch of things that cause dementia. And I just wanted to highlight that because as a geriatrician, who I take care of people with dementia, I see how much people fall through the cracks in the healthcare system when they have these cognitive, like conditions like Alzheimer's and other types of dementia. And our palliative care team is just so excellent in helping support, because when somebody has a dementia diagnosis, it usually very much impacts the people in their life as well. It's not just a diagnosis just for the person who has it, as with many serious illnesses. And our team's so incredible. And then MPTF has so many other resources available for people with dementia. We have even a federal grant where we have all sorts of educational programs for the caregivers and one-on-one care counseling that our social workers do through the Elder Connection program, and social calls to help people deal with the isolation that can be so common in dementia and make dementia worse. So, people might not think of that. People might have an advanced lung disease and not think of that. I like the way you put it there, Linda, that any system that's really kind of not doing well, in the failure state, serious illness, palliative care is there. Can you describe a little, you mentioned a chaplain, social worker. What's it like? How does it work? What's MPTF palliative care?
Well, we have actually a couple of different, we have what occurs in the long-term care setting, which is slightly different. And of course, obviously, then we're going to rooms and caring for people in their room. And that's chaplaincy, nursing, provider, such as myself, social worker. in the clinic setting, which is really where about 70% of our patients are from. They live in the community and they generally are seen in the clinic, or in the last year they're seen virtually. But that then involves the social worker and the chaplain and the physician. And so it may be a visit with the social worker and chaplain, who generally go tandem in their visits. They meet together with somebody, because there's just a really good, I've heard it described as a dance that kind of gets, they're able to bring out more from being together in the meeting. And then they'll meet with the provider. But what's been really happening a lot with Dan and the social worker and chaplain, Ann and Rabbi Arthur Rosenberg, they meet together, so that the virtual visit, all three of them are on the call. And that's really, that dance has become that much more rich in the experience for everybody, because there really is a building on what each other's expertise is. And I said, our patients are really benefiting from it.
So just to highlight, you are continuing to offer palliative care to people through Zoom.
Absolutely. And we've gone up, the number of patients that we served in 2020 was up 30% over what we did the year before. I mean, the programs continue to grow. And I think it's just, serious illness is very isolating. Being in a pandemic is very isolating. You put the two together and it's, people, they needed connection, they needed support more than ever. And so that's where, we just ended up serving more people.
So Dr. Karlin, you're the newest member of the team. What does it look like with fresh eyes?
Yeah, so to put it in perspective, I think I started in February of last year. I had like a couple of days in clinic, and then everything changed. And so everything went on Zoom. So I feel like I know there's more on Zoom than I do in person, but what it's allowed for is the fact that we can just always coordinate so that it's all three of us speaking with a patient at the same time. And what I particularly love is that there are things that I'm going to uncover that if I were alone, I'd be like, oh man, I wish I really had my chaplain here. I wish I really had my social worker here. There's things that they will find that they need a quick medical answer as they're talking to someone, so they can make sure that they're on the right footing to be able to talk to a patient. But it is that dance. But what I've come to really appreciate is just how gratifying it is to work together, because every time we do it together, we feel like we're getting to something true and something deep about a patient. And that's been the most wonderful part. So that's the part that I find keeps drawing me back and keeps me wanting to do it. I'll say, in terms of like what we center our visits on, what you'll find is that we're talking about what are the symptoms that are getting in the way of someone's quality of life. Is it pain, nausea, difficulty breathing, appetite, constipation? What can we do to make the day-to-day life better? And then what questions someone might have about their illness and what they need to do to plan for the future. And that means things like advanced directives or any documentation that they want. But it also means like a lot of conversation about who are you as a person? What do you find meaningful and valuable in this life? And that's extended too in Ann and Arthur's work, is exploring their faith, their background, what they draw on for strength. And also, what are the resources they need to tap into to get the most out of life and get the most out of their benefits. I also want to point out to, Kathy just mentioned as well, that Ann helps organize the Advanced Healthcare Directive workshop, and her email is on the chat. This is a fantastic thing. If you've ever thought about filling out an advanced directive, if any of what we've said has enticed you at all, please reach out to Ann. I highly, highly recommend getting some exposure to this. Even if you don't fill one out, just hearing about it and talking through it would be a wonderful thing.
Yeah, so you basically, you hit on this, Dr. Karlin, that one of our attendees put something about advanced directives in the Q&A, and that's a very important part of your work. I mean, it's really discouraging when you look at it, right? How few people, I mean, why, can you just hit again on why it's important to think about these things? This kind of goes under the whole mythology of do it later versus what's the advantage of thinking ahead on this?
Yeah, so I will say I have an advanced directive. And the reason why I do that is I am not facing any illness right now, thankfully, but I want my wishes to be clear so that I can relieve the burden of decision making off of my family. And the person on the Q&A said that it can be a gift. I truly believe that when you are able to put into writing what your wishes are, even if you know that your children would make the same decisions that you are taking that decision-making burden off of their hands. And what's been one of the most incredible things has been actually to say with families in the hospital setting who were facing really serious illness, that don't worry, they already decided for you what they want. And if it was a decision that they knew their family would struggle with, there it was in writing, and those were their legal wishes that we were obligated to protect. So if at all, if you think that life on a machine is not what you want and you want to make sure that that's protected, write it out. If you want the opposite, write it out. But as long as it's down there, it really just helps your family to follow your wishes quite clearly, and do it early, do it when it's not needed.
And Linda, in addition to all of the great things that have been described, we have plenty of anecdotes, plenty of stories about how meaningful this service has been to people, but you've actually looked at it. You've surveyed people, to just get all perspectives. You've actually even looked at people's insurance claims to see, does it have an impact? Does it impact things like how often people end up in the hospital? And so what can you tell us about that really holistic view of the service impact?
Well, certainly what we've heard from people when we've surveyed patients themselves or their families is that they are feeling supported. They do feel like their quality of life has improved, and that they're feeling a better sense of well-being. And what's interesting with some of the people is that when you get down into the individual symptoms, the pain may still be there at some level, the shortness of breath may still be there at some level, and yet they report feeling a better sense of well-being because they feel more in control and supported. As for the nuts and bolts that we've been able to analyze through working with one of the insurance payers and having them analyze their data, they looked at a group of people that are identified as having serious illness that would be appropriate for a referral to palliative care, and then carved out the group that was actually being served by MPTF's palliative care program. And so they're, like-minded, like diagnoses and situations, but once one group was being served by MPTF palliative care, and the insurance company came back to us and through their data showed that people being served by our program were half as likely to go to the ER, half as likely to be hospitalized, twice as likely to have an advanced directive. It's just, it's overall their quality, the quality of their existence. People want to live at home. They don't want to live in a hospital. So
Right.
Prevent hospitalizations and give them better symptom relief. It kind of feels like, why would you not be ready for that?
Yeah. So it's living, as you said so many times, living well, living well, aging well with dignity and purpose with serious illness. And, I'm looking in the chat and the Q&A, and I see, people say, don't forget to talk about our caregiver support group. What about our grief support? There's so many resources, and maybe somebody could just put in the chat just the general intake line, info lines, so that people can start to tap into all of these great resources if they haven't already. And to that effect, Dr. Karlin, I'm curious. So again, fresh eyes, palliative care, there's programs everywhere. It's not everywhere. We wish it were. But this is crazy. We're just one industry community. What is this typical? Is it, this, or is this, yeah.
It is. So I will say without a doubt, and I'm going to be absolutely brutally honest here, this is far better than what we have at UCLA. It's actually, I feel embarrassed for my own institution that we here at Motion Picture, what's so clear is that they set out to do this and they decided to do it right from the get-go. And most other palliative care programs that are around Los Angeles and most of them in the country, they've taken years upon years upon years, starting with only a physician, not even having the social worker or the chaplain. And this was just created with the intent of providing the best quality care they can. And I have to say, it absolutely shows. And I love being here because this is that dream, like you were talking about, Scott, of what I saw in San Diego, of like, oh wow, this is what palliative care can be if we do it right. This is the first real one that I found in a long, long time that actually really lives up to that. So we welcome anyone. Come and have a taste of it. You'll be sold. It's I don't know. I'm sorry if I'm marketing it. This is the way that I not only wanted to practice palliative care, but in a lot of ways, this is the way that I wanted to practice medicine. We bring the human aspect back into medicine, and we honor people and the people that they are. So it's really love to see that and to be working in something like this.
That is great to hear, and really hats off to Linda's leadership for just not even settling with that, working tirelessly to even improve more and get more services, access, coordination, resources for people. And that's what this is all about. So Linda, we're running low on time here, but go for
I
it.
just want to really quickly say, so we're talking about palliative care and accessing, and yes, the insurance pays for the physician visit, but all the rest of the service, chaplain, social worker, everything else, coordinator, myself, that's paid by MPTF. We don't charge for it. We know it's just what this organization does. If somebody has a need, we want to be there for them. So that's just part of what donations to MPTF does. So this is not a pitch.
Well, excellent. I mean, I think that I'm so grateful that we had the time to connect and to have another one of these great community forums. I'll highlight also that we did mention all sorts of resources for people with Alzheimer's and other types of dementia. So we have a partnership with Alzheimer's LA, and we have another town hall kind of thing coming up with them, where it's a film and discussion about kind of new diagnosis of Alzheimer's with a Ask the Doc with yours truly. And I don't, if somebody could put the date of that, I know it's later this month. I would love to see all of you there, and let people know if you know somebody who's an industry member in your life that has an Alzheimer's diagnosis or is caring for somebody with an Alzheimer's or any type of dementia diagnosis, please let them know so that we can spread that great information. And then just again, thank you, Linda. Thank you, Dan, for everything you do and for spending this time with us here today. And thank you all for attending.
Wow. As always, I've got like my notebook because I always learn from all of you. Dr. Karlin, Linda Healy, Scott, Dr. Kaiser, thank you. Gail, Bruno, Pat, Linda Z, Linda C, the people who are active in our chats. I hope you all got the information that you need. I just put in there our intake lines. There are two. Don't worry, by the way, if you ever get one of them wrong. We do have like the under 65, the over 65, but what we really need is for you to just get in touch. So happy. I'm a Bruin. I love all the rivalries, right? Like, it's fine. I worked at USC Health and I was beyond impressed, and I always will be. Don't talk to me when we play each other. Beyond that, right, Dr. Karlin, like beyond that, we're fine. And we're so proud to have this leadership. Linda, you are phenomenal. Scott, you are phenomenal. Dan, Dr. Karlin, Dr. Kaiser, I should do the professional names, but honestly, that's what it's about. It's the human aspect. It's what you guys all brought up. It's why this is so wonderful and why you're all so engaged. Misconceptions, caregiver support. Please reach out to us. I think that we've given a lot of info. If we didn't touch on anything, if you want the recorded version, we do put things up on our YouTube channel. Our website is a resource. It is not a solicitation device. It's a resource. I'm the solicitation device. If you have anyone, right? Like, that's my unofficial title. Because Linda, you said it great, right? Like, these donations, we don't work on commission. We're not a retail store. We do this so that we can provide the utmost standard of care, quality, excellence. It is what UCLA Health stands for, our incredible partner. The Optimism Campaign, which was just one of my favorites. Like, it's why we do this. I love seeing this Sharon. Great. Yeah, The Father. Yes, there's so many films out there, by the way. We just partnered with the Bright Focus Foundation. Scott sits on the board, and you know, neurological diseases and educating people. There's a lot of films out there. There's a lot of TV shows. There's a lot of resources, but it's living well, it's aging well, and it's really about the human connection. We're so happy to have you all. We will continue this. I will also ask you, you know, if we want to end with a little bit of homework, we're really proud of these webinar resources. If there are other subjects you want us to talk about, tell us. If there are questions you have, reach out to us one-on-one. But if there are things that the mass might want to know about, this is our best attended resource, I think, so far. I actually want to go back to when we started this. We had Agapi Stasinopoulos, great Greek name. Her sister, Ariana Huffington. We talked a lot about mental health and just dealing with all this. I think mental health is always, you know, part of the conversation. No matter who you are, let's not stigmatize it. Some of us may have seen a great interview on Sunday where some people believe and not. That is a part of all of the mental health conversation, whether you believe it, whether you don't. It's real. We know that. You all know that. But let's be better together, and we are better because of you. So thank you all for joining, and can't wait to see you all in person. So virtual hugs. Thank you to our panelists. Thank you, Kathy Davis, by the way, who orchestrated this perfectly, right? Like snaps, whatever we want to do, hand raise on Zoom. Unsung heroes. She's one of them. So yeah. Bye, everybody. Thank you. We're so happy to have you.